Hello people, in this video we want to look at the treatment of gallstones. So basically, what are gallstones? Cholelithiasis we have already covered in pathology. So basically you have cholesterol stones, bile pigment stones and calcium salts as gallstones. So you have seen cholesterol stones, how they look. This is this one is calcium. What is the middle one? We said some pigmented bile pigment, right? Bile pigment stones. And then you have mixed gallstones. We also looked at the complications of gallstones. That is, it can lead to cholecystitis, then mucosal, empyema. I thought this word is used only for lungs. Gallbladder cancer. See, stone can lead to cancer. Cholelithiasis. What is this? Cholelithiasis means the duct. Can lead to some fistula. Pancreatitis, very important to know. It can lead to pancreatitis, okay? It will block the way, and pancreatitis is more severe condition, right? Gallstone ileus. So we have also looked at this why does it form, right? The gallstones, because of bile saturation, cholesterol nucleation, gallbladder hypomotility. So it can form a nucleus and form a stone. Okay, so all this we have looked at. So basically we want to look at the treatment now. Okay, so we have taken a small recap of everything. How do you treat gallstones, guys? There is medical treatment. Basically this is indicated only for the pure cholesterol, that big egg kind of a thing. Pure cholesterol stones only you can do this. Okay, and how will you do it? You will orally, you have to dissolve it, or you have to direct contact the solution. Okay, so you can dissolve this stone if it is pure cholesterol. Otherwise you have to do laparoscopic cholecystectomy. So all this you have to explain in the exam. Surgery topic this is, right? So let's get started people with the treatment of gallstones. So basically you have one more you can add here. Treatment of the pancreatitis, or treatment of the complications you'll have to look at. Okay, that also we will look at. First, let us look at the medical treatment of gallstones. Is it even possible to treat gallstones medically? Yes, only if it is of pure cholesterol variety. Okay. And how will you choose the patient for this medical treatment of gallstones? The patient should have a functioning gallbladder. Okay. And this should be a thin patient, so you can directly contact, kind of, right? You have to go through it. So a thin patient is required. Usually they are talking only about thin young female patients. That sounds a little weird. So they are looking only for thin young female patients, and these stones should be tiny. I think that you would have guessed by now. The stones should be tiny, translucent and floating stones they should be. Just brought in all the points here for you. So these are the way you will select the patient. The stone should be small, the person should be thin also, right? And they should have a functioning gallbladder, and it should be pure cholesterol stone only. Okay. Then tiny pure cholesterol stones, if they are there, very good. Okay. Drawbacks that recurrence can occur, and lifelong you have to maintain. Looks like after dissolution of the stones, lithotripsy or extracorporeal shockwave lithotripsy should be done. That means you have to break these stones. Looks like, right? Lithotripsy means you have to break them, right? Extracorporeal means the waves are going from outside the body. Extracorporeal shock waves. The shock waves are sent from outside the body to break these stones. But what is dissolution and what is lithotripsy? Dissolution is the same thing that we know how it is dissolved, disintegrated, or you separate it in kind of a thing, right? English wise, these two look the same. Anyway, so medically you will do, but what treatment should you give? So these are the treatments. What treatment will you give if you want? These are the treatments. Okay, you will give oral dissolution. Oral dissolution means what will you give? And direct contact, what will you give? Okay, let us see. Oral dissolution, you can give them some chenodeoxycholic acid. Chenodeoxycholic acid. Zoom please. Yes, chenodeoxycholic acid. Deoxycholic acid. CDCA. Chenodeoxycholic acid. So this is the drug. Then you have UDCA also. Wow. Can you remember these names? Deoxycholic acid. Deoxycholic acid common. Urso. Wow. So these drug names, if you give this, then it will dissolve. Nice. What do? They inhibit the HMG-CoA, a rate limiting step in the synthesis of cholesterol. So cholesterol synthesis will be stopped. So stop the synthesis of cholesterol. So inhibit HMG-CoA. Okay, they inhibit HMG-CoA. This is actually a treatment. They inhibit the HMG-CoA and it will stop the synthesis of cholesterol, thereby increasing the bile salt pool. And what does this UDCA do? It decreases cholesterol absorption in GIT. So your body will have less cholesterol. That's it. You're going to stop the synthesis of cholesterol and also you're stopping the decrease of absorption of cholesterol. So what will happen? There is less cholesterol in your body. So how will the cholesterol stone form, right? But if it is already formed, they are expecting it to be dissolved, right? Dissolution is the word they're using. Now let us go down here, guys. Direct contact dissolution. Methyl terbutyl ether. Methyl terbutyl ether is a drug which is given through a catheter placed in the gallbladder percutaneously. That's why they need a thin female. Why? Female, they didn't say why, but thin, yes, because percutaneously, via the skin, you should reach the gallbladder and put some drug into it. That is methyl terbutyl ether. I'm going to put methyl terbutyl ether. I'll pour it into your gallbladder. Okay, what will happen? Your gallstone, if it's pure cholesterol, it should dissolve. This is the direct contact. Okay, MTBE. I'll put MTBE. What is MTBE? Methyl terbutyl ether. Correct? Methyl terbutyl ether. Is that correct? Yes. Methyl terbutyl ether. Where do you use this? To put it into the gallbladder to dissolve pure cholesterol stones. Very good. Explosive and toxic if it enters bile duct or duodenum. Whoa, this looks scary to me. So by mistake, I put it into your bile duct or duodenum. Explosive and toxic. Okay, I think this toxic part is for this. Why will it explode inside? Toxic if it enters bile duct and duodenum. Otherwise, it is explosive, looks like. So that's why you'll see OT fires and all, right? This could be one of the causes of that. What do you say, people? Yeah, scary. What is that? MTBE. Okay. Then indications. High-risk patients with symptomatic stones refusing surgery. These people are like, no way, I don't want a surgery. Then give them medical treatment. The patient must have patent cystic duct. The cystic duct should be patent. Okay. Where is the cystic duct, by the way? See, the duct is coming out of the gallbladder. Cystic duct comes out of the gallbladder. So, and you're pouring this MTBE into the gallbladder. So, definitely this duct should be patent. Otherwise, what will happen? This toxic substance will get accumulated. But anyways, this substance is toxic for the duct and the duodenum, did they say? Yes. Correct. What is bile duct and what is cystic duct? Are both the same? Bile duct and cystic duct? No, they are not. Then what is the difference? Where is bile duct? Bile duct is here. See, bile duct comes after the cystic duct. Cystic duct is joining the bile duct. Okay. So if it enters the bile duct, it is dangerous. And if it enters duodenum, it is toxic. Okay. Fine. So where will you put it? You will put it into the gallbladder. Okay. But if it enters the cystic duct should be patent. From there, anyways, it will enter the bile duct and the duodenum. But that is fine, looks like. Right? High risk, anyways, in the gallbladder, whatever stone is there, it will have to dissolve. Okay. High risk patients who are refusing surgery, patients must have patent cystic duct, we told you. Side effects can be hemorrhage and catheter displacement. So this standard for everything you will write, hemorrhage, catheter displacement. You would have put a catheter, right, to put the drug. See here, catheter is placed in the gallbladder. Okay. So this is the medical treatment of gallstones. Guys, you have looked at the medical treatment of gallstones. Okay. So in gallstone treatment, we had to look at the treatment. We have finished this. Now let us go to laparoscopic cholecystectomy. Yay, we have finished the medical treatment of gallstones. Now let's go to what? Laparoscopic cholecystectomy. So you're going to remove the gallbladder. Let's see. Laparoscopic. See guys, we are looking at the surgeries for gallstone treatment, right? Now laparoscopic cholecystectomy. Earlier they were doing ERCP followed by open cholecystectomy. ERCP means what? Endoscopic, retrograde, cholangio, pancreatography. Such an easy name, right? ERCP. Okay. So that's what they were doing, followed by the open cholecystectomy. So open the abdomen and remove the gallbladder. But nowadays you don't do all that. You do laparoscopy. Very good. So let's look at the procedure. They have shown here some diagram as to where and all they'll make the incisions for laparoscopic cholecystectomy. Where do you think they are making? Okay, because it's laparoscopy, they need multiple ports. The camera is going via the umbilicus, looks like. Okay, or around it. And there's a fundic traction, retraction of neck, dissection port. Did you understand anything at all, guys? Let's read about this. So guys, this is very popular nowadays, and 95% of gallstones can be removed just by laparoscopy. Okay, no need to cut open the abdomen. But like you understand that you'll have to make a lot of entry points in the abdomen. But the concept is that multiple small wounds will heal rather than one large wound. Okay. So this is what it is. There are multiple ports that they're putting, one dissection port, one camera port, and etc. So let us look at this. It's popular. More than 95% of gallbladder stones, gallbladders can be removed. Okay, they're talking about removal of gallbladder irrespective of what the cause is. Okay, they're talking about removal, not this of the stones, the gallbladder itself. So the hospital stay is just 1 to 2 days, and the recovery is fast. The pain is minimal. Mobilization of the patient is much better and easy. It is acceptable. Cosmetic result you will get. Complications are also less, like adhesions and incisional hernias are less. Because imagine if there's a huge cut across your abdomen, then you can have a hernia, right? That's your contents or like bowel, etc. can come out of that and cause a hernia. Because you'll have a weaker abdomen and abdomen wall in an open operation. But laparoscopy, not much of problem with incisional hernia, etc. So now how do you do this laparoscopic cholecystectomy? So you will make 1 centimeter incision made below the umbilicus. Okay, so it is below the umbilicus, right? Not the umbilicus, but below the umbilicus, through which the pneumoperitoneum is maintained by carbon dioxide in sulfation. So they will pump carbon dioxide into it and it will inflate, okay, the abdomen. So you would have seen it in laparoscopic surgeries, I hope. Following this, a laparoscope is introduced and a camera is attached. So through this, what they will do, they made a hole, right, incision, then through that hole they are putting a laparoscope and then a camera. So camera is going in where? Camera is going in near the umbilicus. Okay. Then what are they doing? 3 small 1 centimeter incisions are made. Where in all? In the epigastrium, 1 centimeter in the right hypochondrium. Where is this? This is epigastrium, I'm sure. Above the umbilicus is epigastrium. Okay, so this makes sense. Where is this right hypochondrium? This one, right? Okay, this is ½ centimeter, is it? Incision. It looks like a smaller, yeah, ½ centimeter, correct. Okay, then where is the third one? 3 small 1 centimeter incisions are made in the epigastrium and half in the right hypochondrium. Where's the third one, guys? These are used for suction, instrumentation, cauterization, dissection, retraction purpose. Okay. Then what they will do? Cystic duct and cystic artery are clipped. So obviously you're removing the gallbladder. What will you clip? And you will clip its blood supply, right? You don't want any more blood supply to that place. The duct also will not get anything from the gallbladder. Alright, guys, draw the diagram in the exam. You'll get a lot of marks. This is gallbladder. This is cystic duct. Come on, cystic duct, look a little more better. Yeah. So this is gallbladder and this is cystic duct. So they'll have to clip the cystic duct and also the artery which supplies this gallbladder from wherever that is coming. So you will have to clip this also, right? So you'll have to clip these two. I think you will get very, very good marks if you draw anatomy. Okay, whatever ducts we showed you that time, the see the right hepatic duct, left hepatic duct becomes the common hepatic duct. Then the bile duct to which the cystic duct opens. Then you have come down here. Then you will have this opening of this pancreatic duct, that is the sphincter of OD. What will you do, guys, if you are examiner and you're correcting papers and somebody has drawn this? You'll get a lot of marks, right? You will give a lot of marks, right? Yeah. So then gallbladder is removed using gallbladder holding forceps. Just so easy. The forceps name itself is gallbladder holding forceps. Okay. And is brought outside through the epigastric port. So where is the gallbladder going to come out? From this epigastric port. Oh, nice. Okay, they're telling from where it comes out. Okay. Then, if there's bleeding from liver, it's controlled using laser cautery. Okay. The procedure is done under general anesthesia. You have to give general anesthesia to this guy. Okay, we'll give general anesthesia. And it may take 1 to 3 hours depending on the surgeon. It's not a small surgery. It takes 1 to 3 hours because many surgeries don't take this long, and especially laparoscopy. Wow. This is quite long according to me. Okay, now let's move on, guys. When will you convert this into open procedure? Your intention was just to do it laparoscopically, but you may have to open it up. When? If it is very badly contracted, if it's fibrosed gallbladder, right? Fibrosed gallbladder. If it is very difficult, gallbladder Calot's triangle, this anatomy, very, very difficult anatomy is there. What is there in the Calot triangle, guys? It's very important to know, because you should not injure the structures there. Then what will happen? There will be injury to the bile ducts and it can cause stricture. This is very, very important. Okay. Partial cystectomy may be a safer alternative. Okay. So instead of removing the entire gallbladder, a partial cystectomy could be much safer. Okay. Let's look at this Calot's triangle. Calot's triangle. Yeah, where are you? Here. See, this is the Calot's triangle. We have put the labeling here. It seems to be between the common hepatic, see, right hepatic and common hepatic, between that and the gallbladder. What is there here that is so important? Calot's triangle. CALOT. See, in this Calot's triangle, there seems to be an artery, right hepatic artery and cystic artery. Cystic artery, anyways, we are ligating. But right hepatic artery, they seem to be very concerned about this, okay? So you have this right hepatic artery here, okay, guys? So that is why they are very concerned about Calot's triangle, okay? So if you cannot find this triangle, then you better convert it into an open surgery, and it's better you do a partial cholecystectomy. Okay. So that's it, guys. You have looked at how to remove the gallbladder surgically. Great. Guys, what will you do if there is a complication? How will you treat? Most of it again says you have to remove the gallbladder. Okay, gallbladder cancer, you have to remove it. Pancreatitis, if there is pancreatitis, again you'll treat the pancreatitis and again do same thing. What did we say? Cholecystectomy. So if gallbladder cancer is there, cholecystectomy. If gallbladder wall is involved, extended cholecystectomy. What do you mean by extended cholecystectomy? Regional lymph nodes you will remove. You'll remove some part of liver, looks like. Okay, everything. So just look at this. A little of liver and a little of lymph node. Regional lymph adenectomy. Okay. And what else, guys? Okay, so that's what they're talking about. That will be extended cholecystectomy. Then radiation has small benefits, so we'll not read that. Chemotherapy has been tried. They just tried it, but we don't know if it works. Is it? They didn't say more. 5-FU, mitomycin C, standard things that you give in cancer treatment. Now let us say that person has pancreatitis. What will you do? If the person has gallstone pancreatitis, that is, pancreatitis is because of gallstones, what will you do, guys? What will you do? After this jaundice, etc. subsides, they will do cholecystectomy. Same thing. Cholecystectomy, cholecystectomy, cholecystectomy. Oops, you were not supposed to see that window. Anyways, now we are done with the treatment of gallstones, everything, medical, surgical, and even the treatment of complications to some extent. Bye-bye. Just one more word, guys. If there is mucosal empyema, pus, right? So you will have to give antibiotic also, and you will have to drain the pus and also do a cholecystostomy, okay, to drain the pus with the removal of gallstones. Okay, so you can open up the gallbladder and remove the stones. Cholecystotomy.